certain chemical. And generally, this also is supporting the findings from the epidemiological studies that can only prove association. So there is generally this very important setting in risk assessment with using each one of the components and addressing each one of the components gives you a clear causality proof. With all mixture approach, you give all the chemicals together, or in certain cases, you give the soil to the species that is, you know, in your testing soil directly that you took from the farmer, for example, and you expose them to the soil. It looks great in words, but what is the problem there? First of all, reproducibility of these results. You know, if we would have seen that only synergistic effects will happen, or only antagonistic effect will happen, you know, really testing one component by one would have been little informative for public health. And would be, I would say, a shock to the system if we would have observed this kind of effects. But with the component-based approach, we can say, at least for pesticides, and again, this study was on pesticides, not necessarily this applies to other chemicals, but our component-based assessments are the best setting to reproduce also the toxicity in mammals and likely in humans, because there are a number of observations that also suggest that even in humans, the component-based approach, the additive effect is actually what we see in most cases. So smoking and asbestos, to make a final comment, is fortunately an exception, not something that is rare, but something that occurs not as default or most frequent option. The problem is we have 300,000 chemicals in our environment, and therefore even additive effects are sadly happening as we speak in all of us and for all the chemicals that we are exposed to. Thank you.
Thank you, Professor Andrioli. And now we are continuing with the session about the population health and policy. And I am inviting Professor Georgina Cooley to give her speech with the title Building Capacity to Address Vaccine Hesitancy through Partnership with Pediatric Professional Societies.
Good morning. Thank you for inviting me to be part of this important activity. And I will present a project in collaboration that we conduct with the Albanian Pediatric Society in collaboration with American Academy of Pediatrics and two other societies of Philippines and Japan concerning vaccine hesitancy. So here I will represent the data of study of Pediatric Society, but working in the Pediatric Infectious Disease Service and being an ITAG part, we face the problem of vaccine and vaccine hesitancy every day. So I have listed here an updated causes of vaccine hesitancy throughout Europe, which is the most important threat of vaccine acceptance in different countries, and who has affected very much and compromised all achievements of vaccination, of appliance of different schedule of vaccination in different countries. And if you see here, we have, I don't know, yes, we have different causes, but always the most important issue concern vaccine hesitancy is vaccine safety, followed then by other concerns, side effects, different mentality of some religions, or conspirative theories on, or fake news and misinformations from media, social media, and other no safe sources of information, and so not scientific. Comparing to the other countries, Albania has been a country, and the mentality has accepted a lot the vaccine appliance until 10 years ago. This is our immunization schedule, and here we have the reported data of Institute of Public Health about vaccine coverage during all these years. But if you see in 2023, immediately after COVID emergency, we have a decline of vaccine coverage, especially this decline is in total in this value, but this is especially concerned MMR. No, sorry. So this vaccine decline of vaccine acceptance has coincided with small outbreaks of measles in our country, and nowadays we have hospitalized children with measles complication at our world. Especially there is a resistance and a hesitancy about the second dose of a measles vaccine. So facing these problems, we decide to analyze and to see what are the issues, what are the causes of this vaccine hesitancy in Albania, and how we can manage this hesitancy and improve the appliance of vaccines in our country. So in this background, we, in collaboration, as I mentioned above, with American Academy of Pediatrics, decided to implement some new practice of communication. Maybe not new, because it is discovered since 1980 in other countries, but for Albania was not well known and not applied in our everyday practice. So we decided to introduce in some pilot areas the motivational interviewing and presumptive format of acceptance of vaccine. I will explain a little bit what is motivational interview. This is a person-centered, evidence-based method of enhancing motivation to change, exploring and resolving the ambivalence, and was originally developed in part by William Miller and Stefan Rolnick in the 80s with persons who were substance addicted, but comparing and evaluating the good results of these interviews and the improvement of the communication between caregiver and the parents or the patients, it is used even the other issues like in vaccines acceptance. So in a motivational interview, the patient is put in the center of communication, and using some methods, we just not only make an academic conversation between a doctor and the parent, but listening, accepting the problems and the requests that the parent represent, we manage and address the discussion toward the acceptance of the vaccine. So the motivational interview is based on some points, which are open-ended questions, affirmation, reflection, and summary. And this collaboration and this interview ensure empathy, partnership, autonomy with the parents without prejudging them, and but making them to change mind and to dress their ambivalence for the acceptance of the vaccine. So this is, for example, one case of one 11-year-old female that it's a conversation with caregiver and provider. And so these are different points of and examples of open-ended questions, affirmations, reflections, and putting the parent in the center. We always ask if I can give or exchange my experience concerning the vaccine, and not making academic and philosophic data concerning the results of infectious disease and so on. So this is the goal project of Albania. This is the same, I think, even in the other countries, in Japan and Philippines, we are still going with this. And I will represent some preliminary data comparing these three countries with different social conditions, demographic features, mentalities, religions, how similar and how different they are in vaccine acceptance. So the objective is this, that we put in the center. It was organized, it trained the trainer. So we prepared facilitators or trainers in Albania just to have a long-term effect and prolongation of this method, and not to have just experts from outside. And the curricula was based in didactic instruction in concerning motivational and interview and the presumptive format of the vaccine acceptance. And then these facilitators, which are national experts, trained the learners who are the doctors, the pediatricians, the family doctors dealing with vaccination, and the nurses who apply the vaccines in different health centers. So to see which is the acceptance and which is the feasibility and the adaptivity of this method with Albanian context, culture and mentality, we conduct a CAP survey, case survey, which is knowledge, attitude and practice survey, and I will present shortly the data of this CAP survey in our country. And these were the goals, the main issues that we want to find out. Which are the vaccines more resistant? How is the acceptance of healthcare workers? How they are familiar with the motivational interview, and to establish a baseline of familiarity and confidence in communication skill. So we prepared simulation cases, this is the draft, the template. So we create our Albanian cases according to the CAP to see what were the vaccines more resistant, and we simulate scenario or parents and different answers to address the vaccine resistance. So in cases of less resistant, in cases of normally resistant, and strong resistant of some parents. And this is just the video that we prepare. Can we play this?
Mirëkita, doktoresha.
One second.
Tani që Albi mbushi një vit, doja të bëja disa pyetje rreth vaksinës MMR.
So there are the Albanian cases created, and we put this in this workshop that we make 2 workshops with the learners, and we see how is implemented motivational interview and presumptive acceptance after the training that we do during the workshop.
Mirëtita, doktoresha.
So the total number of participants were
Mirëtita,
yeah, it's 124, and from the CAP survey, we see that the most resistant or not applied vaccines in Albania are MMR, HPV, COVID-19, which is very, very low coverage in Albania in children, and influenza. So we address these 3 cases, MMR, HPV, and influenza, since COVID-19 is not still an emergency, but we have cases. And these are the most common reasons that parents have given for requesting the delay of vaccines. So the child is too small, there are too much administration in the same time, concerning some vaccine ingredients, the misinformation and the news about connection of MMR and autism, and other reasons that we have demonstrated in this graph. And the topics that parents ask most frequently in the last 12 months that they represent are concerning vaccine safety, the contraindications, the connection of vaccines with autism and other important diseases. So these are the most important issues that we find from our CAP survey. And these are the 2 other CAP surveys done immediately after workshops in Japan and Philippines. And I cannot explain right now because we are not toward the end of this project, but we have similar data with Philippines, but we are different in mentality and the data with Japan. Maybe Japan is more developed than Albania, but we have to compare and to make statistically difference between these countries. And these are feedback that we find in different healthcare about vaccines and acceptance. So, for example, for Albania, it was one of the reasons that the learners represent is that the motivational interview needs much time that we have in our busy clinic in everyday work with a lot of children, or we have to adapt the curricula to the Albanian specific cases. And the Philippines and the other one has some of feedbacks we presented here. So as I say, a motivational interview was a little bit more known among Filipinos and Albania and less known in Japan, but the result of CAP survey after the workshops is higher. So in Albania and Philippines, almost 100%, and in Japan, they still have some uncertainties about this appliance of motivational interview to address vaccine resistance and hesitancy. So as conclusion, we can say that the motivational interview combined with presumptive communication and simulation-based education represent a feasible and well-accepted strategy for addressing vaccine hesitancy in our country. So this international partnership developed successfully local expertise and strengthened the clinician confidence and demonstrated the evidence-based communication methods, which are adapted in our cultural settings. The time constricted time that we have in our daily practice may be so a reason not to implement so much, but knowing the result, and this result, we will see how it will be implemented in vaccine residency, in vaccine appliance, and in preventing infectious diseases. We'll see what impact will have these new methods of communication in our practice. So as we see, it's not need always to make a research, to have very sophisticated labs to do researches and important data, but just with improving a type of communication and adapting this for cultural setting of our country, we can influence and improve the communication with the parents and influence this important public health problem like vaccine hesitancy and vaccine acceptance. Thank you very much. And if you have any question, I can answer.
Thank you, Georgina, for your presentation. If there is any question about this subject.
Yes.
Thanks a lot for the excellent presentation. And as you pointed out, generally safety is the greatest concern. And my question is, do you have here in Albania a surveillance for the side effects or a database there? And if you comment on that, because we have seen, that this contributed generally, to increase the confidence, make more evidence-based decision, and, have a better and clearer picture for all in the topic. Thank you.
Yes, we have a national surveillance, and it is all collected and reported in the Institute of Public Health. So every center, vaccination center, or we in the hospital, which face more severe cases of not very important side effects, but undesirable like high fever, sometimes combined with other specific signs concerning the vaccine. We report it immediately in the Institute of Public Health. There is a pilot program that we now have spread and used for all Albania. So in real time, we can report the vaccine, see what was the patient, the age, the conditions, and the side effects observed. So from my practice, I always, I have more than 30 years in pediatric infectious disease clinic, and we have no important side effects of the vaccine. Some cases we can see, especially with the pentaxim that we use, because we are trying a lot to make attempts to introduce acellular pertussis vaccine in our schedule, but we are still one of a small country that we use whole cell pertussis vaccine, which we know is more reactogen than the others, but the system of surveillance and the reported cases, and then we do a lot of attempts just to consult the parents for continuity of the vaccine, because one parent is afraid after he has a high fever to apply the second, the third dose of vaccine. So in these cases, we make individual consultations, not to interrupt, but to give the right vaccine and to when to do.
Okay. Thank you, Georgina. And now we are continuing with Professor Alban Uli, who is speaking about an analysis of information systems for non-communicable diseases in Albania, potentials for improvement.
Thank you, Professor. Thank you for accepting my presentation here. I will start with some stories to give some context, atmosphere about non-communicable diseases monitoring in Albania. And I will close with some illustrations the bulk of the presentation is about a systematic review of what's going on with these systems. Well, the first story here is about request from state audit for Institute of Public Health to provide evidence of health impact caused by oil industry. There was a case where a foreign company working in Albania on the oil industry, there was a scandal, mostly financial scandal, but the communities there were also complaining, and the state audit was requested to do a review of the situation, and one of the components of that was a specific request for Institute of Public Health to provide evidence. Is the oil industry affecting the health, etc.? So this is the first side of the issue I wanted to share with you, which shows that we are more and more under pressure to produce high quality data about potential health impacts of environmental hazards. And we need good quality health systems. The second one is about Ministry of Health asking for chronic disease data. We need chronic disease data. And we were like, what exactly? Chronic disease data, what they are. So it showed, again, that there is pressure to produce good quality data, but there is also a need to specify, to regulate the communication with politics. Personally, I have a special interest in research, public health, communicating with politics. I consider it important. I have even a module at the School of Public Health about it. And I notice there is a need. We have to clarify what are chronic diseases, what we can do to inform public, policymakers, media, with good quality data, but also in a way which help them understand, not just produce reports which nobody reads, but to produce data which are made ready for action, for policy change. Okay, here is well, I want to start with some logical frameworks. This is not done by us, but it's interesting to put into, in one slide, chronic diseases, the main chronic diseases, and risk factors, causes, how they are caused. And the first thing is that despite the fact that there are hundreds and hundreds of non-communicable diseases, some of them are more important than the others. There is international consensus about those 5 general groups. There are not 5 diseases, not 5 nosologies, are groups, right? Ischemic heart disease, stroke, diabetes, cancer, and chronic pulmonary disease, obstructive disease. And then there are risk factors, exposures, determinants. Some of them we cannot control, some of them we can control, some are under personal control, some are under state or society, and there are some metabolic factors. In some cases, they play the role of intermediary, but sometimes the exposure directly influences the non-communicable diseases as the health outcome. So there, at social and environmental determinants, there are some factors of interest for this conference. And, well, for example, air pollution, occupation, temperatures, there can be food safety, etc. Just examples. Yeah, for me, air pollution is the major thing. Not only for me, but I think there is a general consensus that air pollution is the main cause for a part of, well, let's say, is the most important environmental factor for chronic diseases, for non-communicable diseases. So for some 7 million deaths caused from air pollution, 85% of them are non-communicable diseases. This is made from us. I'm proud of it. We're trying to put together all the information systems we have, and which are typical in many countries, but we're talking for Albania here. And we try to give, let's say, a synthetic answer to that request from the ministry. We need chronic diseases data. And here it's, the start of the work to try and regulate the response to that request from the public, from policymakers. It's a pyramid because there are some, differences in numbers, and the numbers get bigger when we go lower towards the basis of the pyramid. But we can talk about deaths when we measure the health impacts of non-communicable diseases. We can talk about incidence of diseases, so the new cases we count every year, we report every year. There can be hospital admissions, which is another thing, numerically speaking, very different from the incidence. There is the prevalence of the diseases, so how many chronic diseases are already in the population, in community. I put the PHC because it's primary health care, mostly the source of this information. And at the end, there are risk factors. Yeah, you can talk about risk factors, and it's becoming more and more fashionable not to talk about deaths as the outcome, but to talk about risk factors, because this way you prepare the audience for the prevention. You, let's say, focus on the potential for prevention. And in terms of numbers, yeah, we have every year some 20,000 deaths from chronic diseases in Albania. Registers of incidence. Again, I put them in, general numbers because it's not so easy to give you a synthetic number for most of the diseases. We have, for example, 7,000, more than 7,000, they're getting close to 8,000 new cases of cancers every year, 5,000, 6,000 new cases of stroke, the same, almost the same, little less of ischemic heart diseases, 2,000 of heart attacks, 7,000, 8,000 of diabetes, etc. Hospital admissions, you see there are some other information in that diagram. Case-based, for incidence, we have data about a specific case, and we can distribute the data about person, about place, about time. But for hospital admissions, we have only aggregated data. But we have the number of all discharges from a specific disease in the country. It serves for something, but mostly for the burden of disease in the health system. Prevalence, yeah, I put there 500,000. 500,000 Albanians have at least one diagnosed condition by a doctor. And we can identify this from the registries of family doctors. But again, we have to work a lot with the aggregated data to specify if someone has hypertension, diabetes, and another disease. And risk factors, yeah, we believe there are more than 1 million, but for sure there are millions, because we're talking here from tobacco smoking to obesity and other exposures. So just an attempt to synthesize how a monitoring system of chronic diseases works. Here, this is the real model of data flow in the Albanian health system, but not really health system because Instat is outside of the health system, but it gives an idea of the complexity and the fragmentation sometimes of the information system. Yeah, I put Instat at the top because by law is responsible to, let's say, receive data from all institutions. Institute of Public Health is there in the middle. It has some responsibility, but by law, it's much, much weaker than Instat. It's under Ministry of Health, can play with the authority of Ministry of Health. It is regulated, the information system under Institute of Public Health can be regulated by a decree of government on the ordinance of minister, but it has to work with other partners. It has to use the law, the authority, but sometimes ad hoc understanding memorandums, etc. And there is a synthesis of the information systems we have at Institute of Public Health about chronic diseases. The case-based surveillance, which is regulated by a government law and requires every health provider to report a new case of disease, and it's cancer. It's politically speaking now is the most important one. There is stroke, the heart attack, and the diabetes. There is causes of death again, but Institute of Public Health gets them from Instat, so we don't have direct control on the source of information, on the system of information, and on the database. We can share with very hard and complicated memorandums with the Instat, and we can share some data. There are aggregated reports. Yeah, we can receive aggregated reports which come to us via third parties like Health Insurance Fund, Ministry of Health. Ministry of Health still traditionally gathers all data from hospital discharges, while the Health Insurance Fund and Institute of Public Health has an agreement to share data about the prevalence of diseases. So what GPs, family doctors have in their registries, they share every year, and we have an idea what's going on, but with a lot of problems. And of course, there are population surveys. So I see population surveys as part of this integrated surveillance of chronic diseases. And now we are finishing the fourth survey in schools for health behavior in school children. This is a standardized European instrument, and Albania has been part of it for many years. We're starting with, for the first time, let's say, a specific survey on chronic diseases called STEPS, and it's proposed by WHO. We are hopeful we'll be able to gather data this year. So we are in the very first phases of that. It's done in Kosovo. It's done in some other countries in Europe. Typically, it's supported by WHO. It's called STEPS because there are some 3 steps. The first one is, questionnaire. The second, physical measurement from hypertension to anthropometrics. And the third one is, lab. Metadata. Well, you can talk a lot about this science now. It's data about data. It's not real results, but it's the explanation of how your data are collected. And I'm giving only 2 examples here about cancer incidence, how we describe the methodology in a synthetic way of the cancer data in Albania, and we have number of new diagnosed cases with each type of cancer in a specialized health center, expresses cases for a number there. And how we calculate the numerator and denominator. Yeah, we have the information source, the disaggregation we can do, the periodicity, etc. And for the diabetes, there is typically hospitals, and for diabetes is typically primary healthcare. So this is the major thing. And of course, we can do even the limitations there. Part of our analysis was cancer registry. We are working with an European body which has standardized the cancer registry methodology, and we want to be part of the European network of cancer registries. So we're already there. We received for the first time on December last year the first review. So this is just part of this evaluation. So I want to tell you that the information systems are complex. They need standardization. They need continuous reviewing. And for example, despite the fact that we are proud of our new 10 years already cancer registry, there are many no's there. And there are many, especially partials, which means we still don't fully comply to the European standards in terms of quality of data. And here is the bulk of my presentation. It's a SWOT analysis, trying to put together all those systems in a 2x2 table with strengths, weaknesses, opportunities, and risks. And well, it's about risks, yes. Strengths. Yeah, we have an established legal framework. Some would call it not complete. So it gives to the pseudo-public health some responsibility, but no, I'll put it in English, no tools. We have no means to address non-reporting or poor quality by health providers. In the past, Institute of Public Health was more powerful, would send teams, that investigations there. Now, not that much. Yeah, we can provide the data about the whole country, not only some regions. We have some inter-institutional collaboration from 10 years now. We have memorandums. We have built trust, and trust is very important in those information systems. So without trust, especially in countries like Albania, you be prepared for low quality data. Because health providers care for their patients, not how the quality of data at national systems would be. But if you go there, if you show the data, if you compare, if you invite them in conferences, if you, let's say, show how important those data are for health policies, for decisions taken for their work, they start and improve their quality. And when they see that you are serious about your work, they, of course, are more, let's say, serious on their work. It happened in the beginning, for example, some doctors could give you clearly fake data. So we could evaluate them. They're giving the data of last year, for example. You could check them by some statistical means. If you show them those things, they understand that somebody's using the data. And this I want to underline, because if you don't use the data, if you just get, health providers' data, healthcare providers' data, put them in your databases, and then just let there, if somebody would ask for them, they will understand it. So the doctors understand it. You have to use the data. You have to check the quality and make them sure that you know the quality of the data. It's a big lesson we got from our work with the information system. We have some qualified personnel, and we have some experience now working on this. And this is another important thing. For example, if you try to build an information system in a hospital without the qualification on epidemiology and statistics, without the right atmosphere of data utilization, you have the risk that the quality of data will be poor. Because again, it's the data utilization. You have to use, you have to check, and you have to provide reports for them. And we can do reports now. We consider them valuable in terms of, we can do distributions, we can see trends geographically, and in terms of time, we can see how the age changes in the Albanian population, so we can draw conclusions on our data, not just some tables there thrown to, potential users. We can draw conclusions which we can defend. But still there are weaknesses. So it seems like a never-ending story. We learned that in Sweden or in Finland, these are very, very minor because, we were said that their doctors report every case. It's rare that they don't report the case. But here, GPs don't report every case. Sometimes at a health center, they don't know about it, they have to report. Sometimes they just are too busy, etc. So the data which are dependent on the will of the doctors have this problem. We want to make the data independent from the will of the doctors to report them. There are problems with incompleteness. So you can have the data for the incidents, but you don't have, let's say, all the details about the diagnosis, the treatment, the follow-up, etc., which are very important for monitoring health programs. And some misclassification there, which is very much related to the quality of the health system, the capacities of the health system to make the diagnosis. We can do the linkage sometimes, but not fully, especially with the pathology for cancers. This is a major thing, and we're starting this year. It takes a lot of time. We overcome this problem with trust and we're working, but we need people, qualified people, and we need continuation. There are, again, data which we don't make, linkages with, like reimbursements, e-registration, e-referral. I'm coming back to those digital concepts in opportunities. There are disparities. It's different in Tirana University Hospital to regional hospitals, and of course, private healthcare providers. They have their own forms, their own information systems, and you have to adapt to them. So these opportunities and risks can be considered even the conclusions, but I'm going to show you some illustration of our data. Digitalization is a big thing in Albania. Everybody knows about e-Albania. We're getting services from e-Albania, and in health, there is a lot of digitalization going on. The major things are at primary healthcare. Everybody is every visit, everybody going to the GP and having a visit is digitalized. So we hope that we don't need to get reports from GPs. We can get the data from the national database. We just need some adjustments, to do that. There is a reimbursement, digitalization, referral digitalization. We need to use those. This is an opportunity for our information system. So this way, we are not dependent on the will of the doctors. We get the data without asking them to report, because they register every visit, every referral, every reimbursement, because they are required to do so. It's very delicate for them not to do that, because there are inspectors from the health insurance, etc. So we can get the data from the digital system. The hospitals, last year, all regional hospitals now are digitalized, all, let's say, discharges. So we don't need to get just those aggregated data of hospitalization. We can now get case-based data using the digital system. And EU alignment is a big opportunity because, they call it bureaucracy of Europe, but it's about standards. Yeah, we believe that trying to align to all European standards, including health information systems, we will get better with that. So we'll have now a big brother, which will support us, not just watch us. And the risks will remain there. So the Albanian population is very dynamic. We move a lot. We have a large diaspora. We not only use healthcare tourism like other Europeans would do, but our people could go abroad to their family and get diagnosis for cancer, for example. This is important. We may lose a lot of cases for Albanian residents producing the diseases here, but getting, let's say, noticed or letting their traces in the health systems abroad. And this is a problem. So the dynamics of population are key for our information system, because we have to produce the risks. It's not about only the numbers. We have to divide them by the population which produces the numbers, and the risks are important. If we don't know well the resident population, all our time trends can be plagued with problems. So what we're doing, we are producing our data using census, going back in time with some formulas and saying the Albanian population has been that and that, and not just trusting what Instat is giving as resident population. The fragmentation, Instat, Institute, the death thing, the pathology, this must be addressed. And well, coding. Coding. Albania till 3 years ago was working with ICD-9, which is very old. It's a robust system of reporting the diseases, but it was very old and not, the other countries were using 10. Now they're moving to 11. We have 3 years adapting to 10. Now we have to think about 11. Well, in conclusion, I'm giving a few slides with illustration, what are doing with our data, some distribution by regions to see the risk. Do we have a different risk in a population? Is it changing in